Respiratory disorders. First one we're going to talk about is chronic airflow limitations, which is emphysema, chronic bronchitis. Both of those are under the chronic obstructive pulmonary disease category. If you look on the picture here, you have healthy tissue, lung tissue, alveoli on the top, and you have COPD on the bottom. Emphysema is a loss of lung elasticity caused by hyperinflation because air is trapped in the lungs. Alveoli overstretch, become bullae. Bullae is basically a thing that's going to pop. That can happen if they are overstretched for too long. Chronic bronchitis, which is recurrent inflammation, vasodilation, congestion, edema, spasm. Excessive thick mucus blocks the airflow and it causes hypoxia and cause you to retain CO2. Causes of COPD: smoking, alpha-1 antitrypsin deficiency, which is a gene that you're missing. So you may never have smoked, but you could still get COPD. And air pollution or secondary smoke. Signs of COPD, in general, it's difficulty breathing, sputum. The sounds, you're going to have a lot of wheezing. Skin may appear blue or cyanotic. The fingertips may appear blue or cyanotics. You need to assess for level of consciousness, airway status and breathing, pulses, respiration rate, depth, blood pressure, heart rate, oxygen level at room air, color, temperature, and capillary refill. An emergency if peak flow is less than 50% of normal. That means you're having a significant problem and you will probably be intubated, and it is definitely an emergency. You need to get somewhere where they can take care of your respiratory needs. Diagnostic tests to determine what you have. For respiratory problems, arterial blood gases, oxygen saturation, chest x-ray, labs, or pulmonary function tests. The goal is a patent airway. So you need to position yourself head of the bed up, patient's head of the bed up. You need to watch the secretions, try to remove those as quickly as you can. Mucolytics to decrease the secretions that are blocking the airway. Expectorants, which help you cough them up. Hydration, and a humidifier. Teach effective breathing, which is diaphragm breathing. Instead of using your lung muscles, using your rib muscles to breathe, you use your diaphragm to help your lungs expand. Pursed lip breathing, which provides a little backflow that kind of keeps your airway and alveoli open while you breathe out. A controlled cough and an orthopedic position. Bronchospasm, treated with bronchodilators, cholinergic antagonists, and theophylline, which is similar to caffeine. Inflammation, infection, things that will be prescribed for this patient: inhaled steroids, systemic steroids. Try to prevent pneumonia, influenza vaccinations yearly, and Pneumovax every 5 years. Try to conserve energy. Schedule activities so you don't do too many at once. Don't rush. Use your supplemental oxygen and avoid arm raises. So a step therapy that you might consider is Combivent first. You add a beta-2 agonist with albuterol, add theophylline, and add prednisone. So you don't start with prednisone. That's your last line of treatment. Pneumonia. Viral, it's a low-grade fever and non-productive cough. Bacterial, high fever, productive cough. And chest x-ray shows infiltrates. Aspiration pneumonia can be associated with a ventilator or inhaled substances. Treatment: antibiotics, antipyretics, oxygen, maintain the airway, bronchodilators, rest, and the mucolytics. Tuberculosis, what is it? Well, it's a lung infection caused by Mycobacterium tuberculosis, caused by close contact with an infected individual, spread by inhaled droplets, causes night sweats, fevers, difficulty breathing, anorexia, weight loss, fatigue. Diagnosed by positive acid-fast bacilli sputum cultures. Skin testing is only a screening exam, and it's not diagnostic. Isolate all potential TB patients for 2 weeks or until 3 negative sputum cultures. How is it treated? Well, initial therapy may include INH, rifampin, PZA, or ethambutol, streptomycin. After 2 months, you're going to be on INH or rifampin. INH is a drug of choice for high-risk populations. Check LFTs if the patient has liver disease or is alcoholic. Warning: increases dilantin and tegretol levels. And rifampin can cause the body secretions to turn orange and may ruin contact lenses. TB considerations: prevention, family teaching, phone contact to make sure that they're taking their medications. May have to have direct supervision of medications if they are non-compliant. Use precautions to prevent passing the disease and follow up sputum cultures to make sure that it's not reoccurred. Acidosis. So a low pH equals acidosis. The normal is 7.35 to 7.45. So a low pH plus a low bicarbonate equals metabolic acidosis. The normal bicarbonate is 21 to 26. Low pH and high CO2 is a respiratory acidosis, which is normal for CO2 is 35 to 45. For alkalosis, a high pH is alkalosis. High pH plus high bicarb is metabolic alkalosis. High pH and low carbon dioxide is respiratory alkalosis because CO2 is the acid. Pneumothorax. As you can see, you have a collapsed lung. The lung is held open by not by pressure of the air going down into the lungs, but it's held by pressure of the. So basically the lung is held open by the surfactant that is around the lung, and it's the pressure that holds it to the chest wall cavity. Signs and symptoms of a pneumothorax are pleuritic chest pain, shortness of breath, tachypnea, tachycardia, unequal chest expansion, and diminished breath sounds on the pneumothorax side, including cyanosis. Tension pneumothorax, which is pressure on the inside pushing the lungs over, can cause tracheal deviation, distended neck veins, hypotension, compensatory tachycardia and tachypnea, decreased cardiac output, and must be treated promptly. Hemothorax, blood that is in the lungs, in addition to those seen with a pneumothorax, the signs and symptoms are in addition to the ones seen for the pneumothorax. They also include subcutaneous emphysema, percussion dullness over the area of the hemothorax. Pulmonary embolism can be caused by a deep vein thrombus that has traveled, air that gets into the vessels, fat that gets into the vessels, or a catheter. Pulmonary embolism can be caused by emboli stopping the blood flow to the lungs. The classic triad of symptoms is dyspnea, tachypnea, and pleuritic chest pain. Restlessness, anxiety, tachycardia, crackles on listening to the lungs, diagnosed by ventilated perfusion scan or VQ scan, and need pain medication, oxygen, vena cava filter, possible embolectomy. The vena cava filter traps any of the clots before they get to the lungs, and they dissolve without getting to any place where they're going to harm you. Prevention: early ambulation prevents that coagulation problem. Hydration, compression stockings prevent deep vein thrombus formation. Sequential pumps, which is air pumps that squeeze your lower legs. You avoid lower extremity punctures. And anticoagulations with subcutaneous heparin or low molecular weight heparin. Thank you, and that's all for this session.